Congenital syphilis includes stillbirth, infantile syphilis, and late congenital syphilis. Among infants who are stillborn, the most common manifestations are hepatomegaly, bone abnormalities, pancreatic fibrosis, and pneumonitis. The liver often shows extramedullary hematopoiesis and portal tract inflammation. Changes in the bones include inflammation and disruption of the osteochondral junction in long bones, and on occasion, bone resorption and fibrosis of the flat bones of the skull. The lungs may be firm and pale as a result of the presence of inflammatory cells and fibrosis in the alveolar septum. Pneumonia alba. With special stains, spirochetes are readily seen in tissue sections. We will look at the case report from Korea about congenital syphilis, and it's an uncommon cause of gross hematuria, skin rash, and pneumonia. A 22-day-old male infant was admitted with multiple skin lesions and visible hematuria that had begun on the 7th and 14th day postnatal, respectively. The infant was the first child born to a 17-year-old mother. The child was delivered at 39 weeks and 3 days of gestation. The mother did not have a history of prenatal screening. The baby's size were measured length of 50 centimeters, a weight of 3,800 grams, and a head circumference of 40.5 centimeters. The vital signs were also recorded with a blood pressure of 80/50, temperature of 36.5, heart rate of 134 beats per minute, and a respiratory rate of 56 breaths per minute. Edema was noted in both lower extremities. There were multiple ulcerative plaques with crust and extensive desquamation on the face and right hand, and various erythematous maculopapular rashes on the soles and upper thighs. A number of ulcerative papules and crusted vesicles were noted, particularly on the scrotum, as it could be seen on the pictures. The laboratory test results indicated a white blood cell count of 26,000, with a normal varying between 5,000 and 19,000. With 55% of polymorphonuclear leukocytes, 30% of lymphocytes, 11% monocytes, 4% eosinophils, and hemoglobin level of 11.4, and a platelet count of 488,000. Blood urea, nitrogen, creatinine, alanine aminotransferase, aspartate aminotransferase, and total bilirubin levels were normal. C-reactive protein levels were elevated to 20.3 and a total protein level of 3.7 with 1.8 albumin indicated hyperalbuminemia. Urine analysis showed proteinuria and hematuria with 50 to 60% dysmorphic erythrocytes on microscopic examination. Serological tests confirmed syphilis. Rapid plasma reagin titer was 1 to 32 and positive for syphilitic immunoglobulin M. The mother's RPR titer was 1 to 96 and trypanemal pallidum antibody and FTA-ABS immunoglobulin was positive. Prothrombin time and partial thromboplastin time were 10.8 and 35.3 seconds respectively and were both within the normal range. The patient's cerebrospinal fluid examination revealed values within normal limits and was negative for bacterial and fungal culture, not including pleocytosis. The chest radiograph revealed multiple rounded parenchymal nodules that sprouted from the ileum and spread through the lung and were notable on the base of the lung. Bone radiographs of the wrists, elbows, knees, and ankles showed normal findings. Abdominal ultrasonography revealed no significant hepatosplenomegaly. The infant was diagnosed as congenital syphilis with nephrotic syndrome and pneumonia alba. He was treated with aqueous penicillin for 10 days at 8-hour intervals, and improvements in the skin lesions, pneumonia, and proteinuria and hematuria were observed afterwards. Serological and urinary inspections 2 weeks after the termination of treatment revealed normal findings. Clinical and laboratory findings all indicated that the patient had recovered. Congenital syphilis can present with diverse clinical findings and can affect almost every organ. The symptoms are usually identified 3 to 4 weeks after birth. Typical clinical manifestations include rhinitis, maculopapular or exfoliative rash, hepatosplenomegaly, and jaundice. Cutaneous involvement in patients with congenital syphilis has been reported to occur in up to 70% of infants. It is characterized by a rash that covers the palms and soles that may be covered with scales and is often followed by desquamation. Syphilitic pemphigus is another typical vesicular eruption that is covered with a brown callus after the vesicle ruptures. These cutaneous lesions could result from congenital syphilis, but could also occur with Staphylococcus aureus, Pseudomonas aeruginosa, Listeria monocytogenes, Haemophilus influenza type B, Mycobacterium tuberculosis, cytomegalovirus, and herpes virus infections. Therefore, diagnosis requires histologic analysis, dark field microscopy, and an immunofluorescent microscopic test of the serum in ulcerative lesion to determine the causative organism. Nephrotic syndrome is a well-known complication of congenital syphilis that presents with severe proteinuria, hypoalbuminemia, hypercholesterolemia, and edema. One indication of nephrotic syndrome is when the amount of protein excreted in the urine is in a 24-hour period exceeds 960 milligrams. Respiratory distress, described as pneumonia alba, is an infrequent clinical feature of congenital syphilis. A plain chest radiograph examination revealed interstitial infiltrations with diffuse rough nodular variates to band-like opacities that radiated from the hilum. However, such findings and no other discernible etiology can be considered as congenital syphilis, and computed tomography can be used for differential diagnosis. Infantile syphilis refers to congenital syphilis in infants that manifests at birth or within the first few months of life. Affected infants present with chronic rhinitis, snuffles, and mucocutaneous lesions similar to those seen in secondary syphilis in adults. Visceral and skeletal changes resembling those seen in stillborn infants also may be present. Late or tardive congenital syphilis refers to cases of untreated congenital syphilis of more than 2 years duration. Classic manifestations include the Hutchinson triad, notch central incisors, interstitial keratitis with blindness and deafness from 8 cranial nerve injury. Other changes include a so-called saber-shin deformity caused by chronic inflammation of the periosteum of the trabea, deformed molar teeth, mulberry molars, chronic meningitis, chorioreinitis, and gammas of the nasal bone and cartilage with the resultant saddle nose deformity. On the picture you see a portrait of a person who was a painter and also a writer, and whose name was Gerard de Larez, and this portrait was ordered to a famous painter whose name was Rembrandt. So basically this is Rembrandt's friend and colleague who had the case of late congenital syphilis, and you can see some of the classical manifestations, including the Hutchinson triad on this picture. Syphilis remains highly sensitive to antibiotics such as penicillin, a short course of which is sufficient to treat all stages of the disease. Serology is the mainstay of diagnosis. Serologic tests for syphilis include non-treponemal antibody tests and anti-treponemal antibody tests. Non-treponemal tests measure antibody to cardiolipin, an antigen that is present in both host tissues and the treponemal cell wall. These antibodies are detected by the rapid plasma region and venereal disease research laboratory tests. Non-treponemal antibody tests are usually positive by 4 to 6 weeks of infection and are strongly positive in the secondary phase of infection. However, non-treponemal antibody test result may revert to negative during the tertiary phase or conversely may on occasion be persistently positive in some patients after successful treatment. Two additional points regarding non-treponemal antibody tests deserve emphasis. Non-treponemal antibody test results often are negative during the early stages of disease, even in the presence of a primary chancre. If there is a high degree of suspicion, this test should be repeated in a few weeks. As many as 15% of positive venereal disease research laboratory test results are unrelated to syphilis. These false positive results, which may be acute or chronic, increase in frequency with age and are associated with a variety of conditions, including the antiphospholipid antibody syndrome. Treponemal antibody tests also become positive within 4 to 6 weeks after an infection, but they usually remain positive indefinitely even after successful treatment. Historically, treponemal antibody tests have been used to confirm the diagnosis of syphilis in those with a positive non-treponemal antibody test. However, thanks to recent test improvements, some centers have reversed this algorithm and now use treponemal antibody tests for screening and non-treponemal antibody tests to confirm the diagnosis. As with all serologic tests for infection, certain pitfalls must be considered when interpreting these tests, including the timing of the test relative to the infection and the confounding influence of altered immunity, particularly in those who are HIV infected. Syphilis, just to summarize, syphilis is caused by Treponema pallidum and has 3 stages. Primary syphilis, a painless lesion called a chancre, develops on the external genitalia along with regional lymph node enlargement. Secondary syphilis, generalized lymphadenopathy, and mucocutaneous lesions that may be maculopapular or take the form of flat raised lesions called condylomata lata. Tertiary syphilis may cause proximal aortitis and aortic insufficiency, may involve the brain, meninges, and the spinal cord, or may cause focal granulomatous lesions called gammas in multiple organs. Congenital syphilis is caused by maternal transmission of the spirochetes during vaginal birth, mostly during the primary and secondary stages of disease in the mother. It may lead to stillbirth or cause widespread tissue injury in liver, spleen, lung, bones, and pancreas. Most syphilitic lesions demonstrate proliferative and arthritis and a plasma cell-rich inflammatory infiltrate. Gammas have a central area of necrosis surrounded by lymphoplasmacytic infiltrates, activated macrophages, and fibrosis. The diagnostic mainstay is serologic testing. Non-treponemal antibody tests are usually positive in early disease, but may be negative in advanced disease. Treponem-specific antibody test results become positive later and remain positive indefinitely.